It doesn't take long to become addicted to opioids. In fact, 10 Pennsylvanians die from them every day. Geisinger is committed to ending opioid addiction with both prevention and treatment. In the last 3 years, we've reduced the amount of opioids we prescribe by 50%, and we've opened 4 outpatient addiction treatment centers across the state to help patients recover from addiction. Learn more at geisinger.org/recovery.
Additional support provided by the Commonwealth of Pennsylvania and viewers like you. Thank you. Coming up on the next Battling Opioids. Tonight, we hear stories from veterans and the underserved who are in recovery. And we'll learn how they're coping with the stress and the uncertainty the pandemic has produced on the opioid epidemic.
Hello, and welcome to Battling Opioids. I'm Paula Giacomo. In our first story, we'll meet Melinda, a former Navy nurse from Luzerne County who has traveled the world while serving her country. But after gastric bypass surgery, she became addicted to pain medication, and her life spiraled out of control. Her challenges and struggles with addiction led to her making some critical life changes.
Grew up in this area, and I traveled to Great Lakes, Illinois, and that's where I completed boot camp, the United States Navy boot camp, and then I stayed there an additional 3 months once I graduated boot camp to complete corpsman, what the Navy considers A school, and that's where I completed my book training for my job in the Navy. And as I processed out in 2005, April 2005, I came back here to the States, to Norfolk, Virginia. That's where I processed out, and then we came to Pennsylvania. Even before coming back here is when I began struggling with drugs and alcohol. It was just years and years and years of just different things, and I had had gastric bypass surgery a year after my daughter was born, so in 2009, and that was the first time that I abused a drug that wasn't for pain management or anything of the sort. I didn't have any pain, and I just kept taking it because I was trying to numb myself. I didn't know that at the time. I, of course, have learned that since being in sobriety. From then on, it just spiraled out of control. I had had a prescription for Xanax at the time. I was going through a divorce, and the doctor, that was his solution. I was feeling anxiety, he gave me pills, which was standard for that period of time. Only I wasn't taking them as I was supposed to. I was taking them essentially around the clock, and it was not safe. The entire time my drug addiction was hidden. It wasn't something that I spoke about. It wasn't really even anything that I knew was going on. I started taking narcotics excessively, especially once I moved back to Pennsylvania. And it was my solution. It was my solution to everything. It helped me tolerate the world around me. I felt like I could just get more things done. And ironically, I grew up in a family of alcoholics and addicts, and I was aware that it existed, and I always said that I would never allow that to happen to me. So it was very subtle how it weaved its way into my life. And before I knew it, I was in full-blown addiction. I couldn't get out of bed in the morning without taking something. I began abusing anything and everything that I could get my hands on. My preferred drug of choice was opiates. My addiction, it spiraled out of control. In the last year, so say 2016 to 2017 was the worst of it. That's when I was starting to hit my bottom. In November of that year, I had told my husband that perhaps I was having a little problem. I had had a prescription for a shoulder injury, and I had told him, I took the whole bottle over the course of a couple weeks. Really, it was a couple days. And I didn't really let on to how bad my addiction was. I was lying to my husband. I would come home. He would ask me if I used that day. I would, of course, tell him that I didn't. I would start fights to get out of the house to go get what I needed to get. And I could not function without drugs in my body. In the event that I couldn't get a hold of drugs, I would resort to alcohol or over-the-counter cold medications, anything and everything that I could ingest that would alter my perception of reality, I took. I realized that I needed to go to rehab. I told told my husband what was going on, and he said, okay, go do what you need to do. And he dropped me off at Marworth a few days before our first wedding anniversary. And that's when my sobriety began. So my sobriety date is January 5th, 2017. I've not had a drink, a drug, or a cigarette in close to 4 years now. So I will want you to be safe doing so. So don't be afraid, reach out, find someone, there's places everywhere. You know, Google recovery, Google substance abuse, anything that you need to do, just don't keep it in any longer, because the opiates are, so many people have died. People don't need to continue dying. Life doesn't have to be this way.
Recovery starts with a call. Call 1-800-662-HELP or visit battlingopioids.org.
Now it's time to meet our panel. Senator Jean Yaw represents the 23rd Senatorial District and is the chairman of the Center for Rural Pennsylvania. Welcome, Senator.
Welcome. Thank you.
Raphael Bereshansky, Deputy Secretary for Health Preparedness and Community Protection at the Pennsylvania Department of Health. Welcome to you as well, Ray.
Thanks for having me back.
Thank you both for being here to discuss the opioid epidemic. Senator, you were recently reappointed to another term. The pandemic halted a lot of services and hearings that you had regarding the opioid epidemic. Do you plan on stepping up efforts regarding the opioid epidemic in this new year?
There's no question about that. We have talked about it. I've talked about it with the Center for Rural Pennsylvania, with the executive director and the board. And we've, I don't think there's any question that COVID-19 has, and the pandemic has kind of unfortunately pushed the opioid problem to the side. But it's still there. It's there in an ever-increasing way, and there's no question about it. I think that we've lost some time as a result of the pandemic interfering with where we were going, and we need to start the education process once again.
Mm-hmm. You heard in the piece Melinda say, if you need information on drug abuse, just Google it. But the state has its own website, health.pa.gov, that is a powerful resource. Isn't that right, Ray?
It sure is, and thank you for bringing that up. I'll recognize the senator's comments, and it's nice to see you, Senator. And he is correct. We were fighting a very hard battle in regard to our fight on the opioid crisis here in Pennsylvania. And we definitely saw some significant traction in both 2018 and 2019 in regard to a reduction in our overdose deaths. COVID-19, for a number of reasons, has hit us very hard, and we are fighting just as hard to not lose any of the traction that we made in previous years. In regard to our data dashboard, we do have a lot of information up. And I would ask people to go to our the Pennsylvania data dashboard. There's information in regard to overdose rates, in regard to counties. There's a lot of information regarding services that are available in those counties. And in 2021, we're actually expanding the opioid data dashboard with features like Find Naloxone Near You and other new data sets in regard to the services that all of the various agencies involved with the Opioid Command Center can offer to those who need it.
Senator, do you consider rural areas as underserved when it comes to this opioid epidemic?
I don't think that there's any question that rural Pennsylvania is underserved, and it's not. It's the nature of the beast, so to speak. You know, the distance involved in getting services. First of all, there's less services than you would have in a more metropolitan area, and then the distance is a natural factor. They're spread out more. You may have to drive an hour and 2 hours to get to some service, and that's a very, very huge limiting factor on the ability to get service, which raises a whole issue that we can also talk about the importance of telemedicine and broadband.
broadband. There was a recent federal initiative, the Rural Community Toolbox, to connect rural areas with funding just to battle the drug overdose epidemic. Do you see that funding yet, or what needs to be done in order for rural communities to get that funding?
I'm not aware of the funding itself, but there's no question about it. We need funding is critical. Running broadband, fiber optic cable, or whatever is necessary in Pennsylvania in order to get those rural communities connected is expensive. Much more expensive than it would be to do the same thing in a more urban setting. And so it's critical. Funding is critical to rural Pennsylvania.
Why do you think the rate of opioid addiction is so much higher in rural areas?
I guess it's maybe the isolation. We read all the things about what happens with the pandemic has caused, mental health issues. There's suicide problems, and a lot of these go back to the isolation issue. We talked about it earlier. How important is it to have a handshake or a hug? And you don't have that. And in rural Pennsylvania, it's even less of an opportunity. And now we're saying, oh, well, you were isolated before, but now you need to be more isolated. And I think that is wearing on people. I don't think there's any question about it that has had a huge effect on the drug overdose issues in rural Pennsylvania.
Well, the drug overdose problem is not only an issue in rural areas, but in big cities, metropolitan areas as well. And the city of Philadelphia, Ray, started a resilience project to target drug-prone areas like Kensington. Can you elaborate on that a little bit?
I certainly can. So I have to tell you that it's very impressive what Philadelphia has done with their resilience program. It's really been a holistic approach to what they're seeing in the city. And not only does it involve areas like clearing major encampments and trying to reduce criminal activity, but it also tried to reduce the number of unsheltered individuals and as well as trash. And not only all of that, they've also been engaged in initiatives, cutting edge initiatives like naloxone leave behind, which I know that the Philadelphia Fire Department ambulances are specifically involved in. And this is really a cutting edge initiative for the city of Philadelphia. I can tell you that in the beginning of this initiative, they did visit our opioid command center, the statewide opioid command center, a few times. And we have definitely been good about getting information back and forth between Philadelphia and the state to see exactly what's working.
That's great news.
Recovery starts with a call. Call 1-800-662-HELP or visit battlingopioids.org.
Our next guest is Matt McClett. Matt is a military veteran and a psychiatric and mental health board-certified registered nurse. Matt has worked on several opioid policy initiatives. He is the incoming executive director of the veteran service organization Action Tank and the director of clinical operations at NeuroFlow, a digital health company developing mental health and substance use disorder solutions for the Department of Defense and VA. Matt, thank you for joining us on this discussion. What are the barriers to getting veterans and service members mental health and substance use treatment that they need?
All right. Thank you guys so much for having me today. In my experience, veterans are either viewed as this hardened group that can overcome anything, right? We rub dirt in our wounds and move on, or we're seen as completely broken and need of society's help to reintegrate and function. So I think starting today, it's really important that we understand that veterans are people, right? They're people that have served and sacrificed for the country and therefore have a higher rate of exposure to trauma, chronic pain conditions, and some of the unique experiences of military life. And as a result, veterans do have higher rates of substance use disorder than the general public. And stigma continues to keep those with substance use disorder from getting the treatment they need. Military culture in particular presents a lot of challenges here. There's been a longstanding policy of zero tolerance and a perception that a service member will ruin their career and therefore their life for coming forward with a substance use issue. And beyond that, with service members and veterans face internal stigma about fear of being treated differently by their leadership, being seen as weak, or worst of all, that their team's going to lose confidence in them. Veterans also might struggle with understanding why they're struggling, but not their peers, or that they shouldn't be complaining because they know what they signed up for. And all of this really prevents them from speaking out early in the disease process when it is much easier to treat. And in terms of barriers, I think you saw earlier in the segment, alcohol and drugs help people avoid thinking about painful moments and stress in their lives. So the goal should be helping veterans find new resiliency patterns that feel doable and not overwhelming. That may mean having a variety of options, including those we've seen in the VA Whole Health program. Instead, we have a false notion that people have to reach rock bottom to get into recovery. I'm sure in other series you've seen that law enforcement is often the entry point for people to get into care. But research shows that medical providers and loved ones play a role in motivating people. That's why there needs to be improved screening within primary care as an opportunity to educate veterans that treatment works and recovery is possible.
As an expert in behavioral health and psychological trauma, do you have any recommendations for doctors and first responders and community leaders, how they can better help people who experience substance abuse and what they can do to better serve their communities?
Yeah, that's a really interesting question. One of the first things I tell people is just to think about how you speak about substance use. The language that we use really impacts the care that we drive. So what we encourage people to do is use person-first language. So we should be speaking about substance use disorder just like we would with any other condition. To say that someone has an addiction versus that someone has a substance use disorder, using words like abuse and implies volition, right? That it was their fault. And there's actually a lot of research out from Dr. John Kelly up at Harvard that if we actually change the language and start to speak about substance use disorder as we do any other medical condition, it actually opens up a lot more options that providers are willing to provide. So even as like an immediate first step is just thinking about how do you use person first language, avoiding terms like addict and junkie, and starting to think about, how do you say that this is a person with substance use disorder?
Matt, are you surprised by the increase in drug overdose deaths during this 2019 coronavirus pandemic?
I'm not. This is a disease of despair, right? I'm sure that's a phrase that's been used in this program. And certainly when we think about people losing their jobs and kind of not knowing where the next food is going to come from, we anticipate that there'd be more overdose deaths, and fentanyl and some of the synthetic opioids and heroin is what's driving the large portion of the overdoses right now, both in the general and veteran population. So, it's not a surprise. It seems to be the trend that's continuing, but that just emphasizes that we need much more evidence-based treatments available, especially when people ask for it and need it.
Thank you, Matt, for joining us to talk about your insight with the opioid epidemic. Senator Yarl, what do you think about the increase in drug overdose deaths during the pandemic? Are you surprised?
I'm not surprised, and I agree with what Matt said. Everything just leads right into that. It's the despair, not knowing whether you're going to have a job. I talked about an article that I read recently in Philadelphia Inquirer about drug overdose situations involving restaurant workers. Well, that happened at a time, restaurant workers have been on, off, not working 50%, restaurants failing. I mean, you talk about a stressful occupation right now, that's probably at the top of the list. And it all fits together, that people do it to avoid reality.
And it seems people are overtaxed, stressed out. Ray, how does the state deal with a pandemic on top of an epidemic? I mean, that has to be monumental in terms of how to battle these two issues.
That's a great point, and both the previous speaker as well as Senator Yaw brought up some amazing points about our overall efforts. We are working as hard as possible to address COVID-19 through various state agencies, but at the same time, it's important to note that our weekly opioid command center meetings with 18 state level agencies have not stopped. And our focus on the opioid crisis in the middle of COVID also hasn't stopped. And the things that we're seeing, and The disease of despair comment was excellent. We're seeing a lot of loneliness. People are reporting loneliness. People are afraid to call 911. They're afraid to get in an ambulance, afraid to go to the hospital. And these are just some of the areas that we're trying to address as we combat the opioid crisis here in Pennsylvania. And I think that the resultant effects of COVID-19 on the opioid crisis are things that we're only going to see start to play out now, and they'll continue well into the future.
And for some people, virtual meetings are just not the same as in-person meetings, right?
I couldn't agree with you more. I think it was Senator Yaw who said before that some people need a hug or a handshake, and we underestimate how much that means to people. And similarly, when we have meetings, there are times when you have meetings that are face-to-face and you can look at somebody and gauge the way they're feeling and really understand the troubles that they're having in regard to initiatives or funding or things like that. And yes, it's different, but at the same time, I do want to make it clear to the audience, the opioid crisis is a crisis that Pennsylvania government is paying attention to, even in the time of COVID.
Well, that's good to know. Well, the Veterans Memorial Hospital has a strong behavioral health program team that is nationally recognized as being a leader in the field of substance use treatment and recovery. They have a dedicated substance use disorder team with local and national reach that has benefited thousands of veterans and their families. Jonathan Atkinson is one of the experts leading this program locally in Pennsylvania.
Our substance use disorder treatment program is here to assist our veterans with achieving sobriety, as well as promoting a recovery-based lifestyle. Veterans often face difficult challenges, including reintegrating into civilian living, managing chronic pain, as well as dealing with trauma. So we really strive to make sure our veterans are well equipped with the tools needed to promote a healthy and sober lifestyle. We additionally have our Veterans Treatment Court, which works with veterans who have experienced legal issues as a result of their respective mental health or mental health considerations or addiction. COVID has obviously impacted the lives of so many of us, so patient safety remains a top priority. We've done a remarkable job of screening each patient, visitor, and employee who steps in the building, but also with utilizing virtual services to continue to provide care for our veterans. And because of that, we haven't really missed a beat. Veterans continue to have access to our behavioral health services. We've even distributed VA-issued iPads and tablets to veterans who don't have access to their own hardware. The local recovery coordinator serves as a champion and advocate for the recovery model. So the local recovery coordinator serves as a subject matter expert on recovery and implementation to recovery services here at the VA. Our local recovery coordinator also engages in outreaches to the community to provide information about behavioral health services within the VA and advocate for recovery and wellness of our veterans. MakeTheConnection.net is designed to create ways for veterans and their family members to connect with shared experiences and support. This resource can help veterans confront the challenges of transitioning to civilian living and facing mental health issues, including substance use. It's important to know that veterans can also utilize the Veterans Crisis Line at 1-800-273-8255, then press the number 1. They may also text 838-255 or chat online at veteranscrisisline.net. Veterans and their family members have access to connect with the Veterans Crisis Line for 24/7 support. The VA offers a wide variety of resources available to promote recovery from addiction. This includes individual therapy, outpatient groups for substance use disorder. We have 5 groups running throughout the week here at the local VA. We have medication-assisted treatments for substance use disorders. We have intensive outpatient programs for substance use disorder. Our IOP program is a more aggressive treatment option, which runs 3 days a week for 8 weeks. We have our residential treatment program, which opened in 2019. We additionally offer services within our Veterans Treatment Court, which works with veterans who have experienced legal issues as a result of their respective mental health or addiction considerations. we've done a remarkable job of using our behavioral health services by using the virtual platform, and we really haven't missed a beat. In fact, we've been able to provide VA-issued iPads to veterans who aren't able to access the technology independently. So veterans can use this service to achieve sobriety and improve their overall quality of living. It's remarkable because I've seen patients present in their worst moments, and in a few months' time, they've reached significant milestones such as identifying housing if they're homeless or repairing damaged relationships as a result of addictions. And none of these outcomes would be possible without a dedication to recovery. Our services are provided for veterans. However, we are available as an aid and a resource to family members to provide education on the nature of addiction and information on the services that we offer to assist their loved ones in their journey to seeking help. We focus on a holistic approach when it comes to patient care to make sure that we're addressing improvement in mind, body, and spirit. So by doing so, we utilize not only our behavioral health services, but we also rely on our whole health, which has had a tremendous impact on the lives of veterans and offering alternative solutions outside of just strictly pain medication. So in whole health, we offer services such as acupuncture, Tai Chi, yoga, chiropractic care, all valuable resources that veterans who have participated in have seen significant impact in their recovery compared to those who don't. So it's really a multifaceted approach to care as opposed to just one sole treatment. Yeah, we understand that it's difficult to take that first step, but we just want you all to know that we're here for you. Veterans can access these programs by reaching out to their respective VA healthcare team. Veterans may also reach out to the behavioral health clinic directly here in Erie. The number is 814-860-2038. For veterans with urgent concerns, we offer same-day access to accommodate those individual needs. And then upon enrollment to our behavioral health clinic, we'll identify chief concerns, we'll review treatment options, and then make a collaborative decision regarding suitable treatment for the veteran.
Recovery starts with a call. Call 1-800-662-HELP or visit battlingopioids.org.
Let's welcome back Senator Gene Yaw and Ray Bereshansky, Deputy Secretary for Health Preparedness and Community Protection at the Pennsylvania Department of Health. Ray, recently the state launched PA Vet Connect, an outreach initiative. Can you elaborate on this new program?
I sure can, but first I really wanted to highlight how the Department of Military and Veterans Affairs, aka DMVA, is a real partner of ours. DMVA has been involved with the Opioid Command Center since the beginning, and we're appreciative of those efforts. And DMVA has also received a whole lot of state opioid response funding, and that's federal funding that comes through our Department of Drug and Alcohol programs. Some of that SOR funding has actually gone to medication-assisted treatment providers, counseling providers, and other organizations that provide supportive services to both veterans and their families. And so it's through that SOR money, before I touch on your question, that the services include things like housing and counseling and financial assistance and things like that. So I do want to be clear that DMVA is definitely one of our large partners at the Opioid Command Center. And PA Vet Connect is, as you said, it's a resource network that's comprised of regional outreach program coordinators, and it's been developed by DMVA to assist with connecting veterans to any resources they need in state, local, federal, or even any other resources. It's also a part of the governor's customer service transformation initiative, which improves the overall experience of Pennsylvanians dealing with state government. So Vet Connect really helps veterans and their families with a wide array of issues.
So it sounds like whether it's PA Vet Connect or the Department of Military and Veterans Affairs, there are a plethora of resources at the state level that not only veterans, but anyone who would need treatment or resources within, the substance abuse arena, that's where they can go.
I would say there are resources, but I would also say this. This is a group that needs resources. And I believe his name was Jonathan, the previous speaker, did a great job speaking about some of the needs of vets. And as I mentioned, some of those needs when it comes to substance use or even recovery services include disparate areas that we may not think about on a day-to-day basis when it comes to this group. So whether, like I said, housing or education or employment or suicide prevention, these are areas that we need to think about for our vets who may have substance use issues and who may need treatment and recovery services.
Or if they need iPads to connect to a virtual meeting.
Great point. And that actually ties into Senator Yaw's point from before about connectivity and isolation.
Senator Yaw, you were in the military, you served in the Army. What do you think of these variety of treatment modalities that are being offered now to veterans who come home and try to reassimilate to civilian life, whether it's yoga, Tai Chi, acupuncture? I mean, were those things even around when you came home?
No, they weren't. And I will say, I probably, when I was in the military, times were maybe much simpler, or at least I was at the end of the draft stage of the military a long time ago. So I think that the problems that military people face now are much more complicated and more complex than anything that when I was in the service. So I think all these services they're great, and to have them available. My question would be, maybe Ray knows this, is to how these services are made known to the respective county Veterans Affairs officers. Mm-hmm. I think that's important because I know in my home county, the Veterans Office is very, very active and dealing with people. So I think that at the county level, that's a really important factor, and to have that coordination. And maybe we're back again talking about the connectivity and the communication between the Federal Veterans Affairs and our state offices and our county offices.
And it's good to know that there seems to be more crisis lines, more internet services that people can connect to, more of those sources that people can reach out to.
I don't think there's any question. People are becoming more and more educated as to what's available.
Mm-hmm. Well, minority and immigrant groups, people in poverty, how would you say addiction is impacting those groups, Senator?
Oh, I think it's a huge impact for the same thing we've talked about everybody else at a different level. It's to escape reality, to change things, or to avoid make you feel good at the moment. Instant satisfaction from a drug overdose or a drug high. I think that those things probably do impact, maybe, I'm not sure it's just minorities, but perhaps it's based more on income.
Mm-hmm. Ray, would you agree with that?
I would totally agree with that. And I think that the question is good, and the senator's comments are also good. I did want to point out that targeting underserved populations is also something that we discuss at the Opioid Command Center and with our state level agencies with regularity. In addition, I did want to highlight just one additional area, which is the Department of Health's Health Equity Response Team, or HERT, which specifically works with vulnerable populations living with mental health and substance use disorders. It's this HERT team that specifically talks about things like the need for social connections, which I know the senator mentioned before, and and some of those are prohibited due to COVID-19, and also some of the additional stressors on people in this exceptionally stressful time. And so it's this HERT team that also has developed various strategies to mitigate challenges specific to the vulnerable populations, and including areas like naloxone distribution, syringe services program, expanding regulations for the provision of telehealth, and even providing more mental health and substance use data relevant to COVID-19 so that we can get a better grasp on the specific impacts to vulnerable populations.
In Luzerne County, personal advocacy is important in any healthcare interaction, but it is perhaps most important and most challenging when seeking substance misuse of services. Through the personal stories of two individuals who work with people struggling with substance misuse, we will hear about the dangers of personal bias and about the importance of eliminating bias in the medical system to ensure that patients have access to all treatment modalities.
We need to do our best to make sure that whatever door they walk through, whatever group they engage with, understands that there are many different treatment options, so that patients can feel confident that they're walking in and getting treatment that's best for them, not treatment that's best for the provider.
I have not had a drink or drug in nearly 9 years. I was raised the oldest of 3 boys. My brother Todd, who was the middle of the 3 boys at age 28, died of a heroin overdose. About 2.5 years later, in September of 2007, my youngest brother Josh died of a drug overdose. With my brother's deaths, I was the last living child of my parents, which made it all the more difficult for me in late 2011 to tell them that I was struggling with my own addiction to opioids and that I needed to seek treatment.
The treatment of substance use disorder can really be quite different for individuals. The reasons that lead to substance use and harmful substance use are quite variable. So individuals seeking treatment may be referred for any number of different types of therapy, depending on what their individual needs are.
When I started the journey that I'm on today, my view of the recovery world was pretty narrow. Along the way, I was privileged to get an opportunity to work for the Commonwealth as a communications director for the State Department of Drug and Alcohol Programs. I had opportunity to meet many different people, travel across the Commonwealth. I reflected on my family's story. My parents would much rather have my 2 brothers, Todd and Josh, alive today and on a medication that gives them a chance to recover. And so I went from, if you're on Suboxone or methadone, you're not really in recovery, to perhaps one of the strongest proponents of incorporating medication as one of our tools, because we lose far too many people.
My views and my approach to the treatment of addiction and opioid use disorder have absolutely evolved over the course of my career. Early in my career, I carried a lot of the same stigmatized thinking and beliefs that are still really prevalent. And I like to think that evolution in my own personal experience and that progression of thinking helps me to then go and speak to my colleagues, my peers, who are maybe in different stages of that process.
Priority number 1 for me is eliminating the personal bias and the stigma to ensure that the patient gets what is best for the patient. I think for the person who enters the system for the first time, they are relying very heavily, if not exclusively, on the system. And that's what we do when we enter any type of healthcare system, is put our faith and our trust in the experts. We need to be willing to embrace the change that the data and that the evidence and that the lived experience supports. Are we willing to change? It's not lost on me that I am, at least in part, where I am today because my brothers are not here. And I try to carry this message, at least in part, to memorialize my brothers in a positive way. When I'm critical of the treatment system for its stigma against medication, it's purely from a patient-first perspective. Everything that we do should be about making sure that we give that individual the best chance at recovery and really life, because it is life and death.
Recovery starts with a call. Call 1-800-662-HELP or visit battlingopioids.org.
Our next guest is Dr. Margaret Jarvis. She's a practicing psychiatrist and chief of addiction services for Geisinger Addiction Medicine and the Neuroscience Institute. Welcome, Dr. Jarvis, and thank you for joining us. Dr. Jarvis,
I'm very glad to be here.
There has been a substantial increase in drug overdose deaths across the United States, as I'm sure you're aware, primarily driven by rapid increases in overdose deaths involving synthetic opioids like fentanyl. What can we do to curtail this rise, and are you surprised by it?
No, I'm not surprised by it. This is something that we've been aware was creeping up over a number of years. And it's really, really going to be tough to do much about this on the interdiction side. Fentanyl is a very, very potent opioid, and that means that it's tiny, tiny amounts that are needed for each dose. Because of that, it can be sent through the mail, it can be transported in very small amounts for a large number of doses. And that means it's very, very hard to intercept. So the things we can do is to, number one, provide treatment to anyone who wants it. Number two is to really invest in harm reduction strategies. Things like making it legal and available that people be able to test their own drug supplies for fentanyl. And there is technology available to do this. It just needs to be made legal. Things like syringe exchange programs, safe injection sites. Those are things which will help the person who is not yet in a position to enter into some form of treatment, reduce the chance of overdose and death. You can't help somebody who's already overdosed and died. And if we can keep people alive, perhaps there will come a day when they're ready to do the very hard work of getting into treatment. But that's maybe the very best that we can do for them.
So you believe in giving a patient access to a variety of treatment options?
Absolutely. There is not one adult anywhere who wants to have a finger wagged under their nose and be told, here's the way you must do things. None of us like that. And when you can offer people a variety of options, that's what's most likely to get somebody to a place where they are willing to feel that they've been heard, that there's something out there for them and that will meet their particular needs. And that becomes an entry point and maybe the only place they need or want to go. There are going to be people who perhaps make use of something like syringe exchange programs for years and years and years. And if that helps keep that person alive, and that helps to reduce the transmission of HIV and the creation of other soft tissue infections that get people hospitalized and things like that, then I think that's great.
Well, what do you say to the critics who say you're enabling them, you're continuing their drug use by, medication-assisted treatment is just another drug? What do you say to those critics?
I would say that the science says you're wrong. The science says that this is a way to keep people safe, number one. And that's the biggest deal. Keep people alive. I would also say that when you look at the brain functions that are disturbed by addiction, by substance use disorders, there's an enormous difference between what happens in the course of someone seeking drug in the street, going to various medical facilities and presenting with untruths in order to get drug. That's the substance use disorder. When somebody is taking a medication as prescribed and they are getting on with their day and they are being functional, taking care of their families, going to work, paying taxes, that's not a disorder and that's not enabling.
Mm-hmm. Between March 2020 to May 2020 was the largest increase recorded in drug overdose deaths in the United States during this COVID-19 pandemic. Other than what you just described, is there anything else we can do to help curtail these numbers, Doctor?
Sure. There's plenty that we could do. And number one is just making access to these things so universal and so easy and readily available. And there are lots of really wonderful, compassionate people who've devised creative ways of making these treatments available. And I've been really, really encouraged and happy to see that organizations within the federal and state government have done things to try to make this work better during the pandemic. There's a lot that has been done. There's a lot more that can be done. Things like stigma reduction programs. A lot of people are still very reluctant to seek any sort of help just because they are so ashamed and they are afraid of what happens if they acknowledge that they have a substance use disorder. Mm-hmm. The science hasn't been developed. The policies and regulations haven't been developed. What regulations there are often rooted in technology and science that was available in the 1970s. And this is really causing problems in terms of trying to take a more modern, more scientific, and more compassionate care to that population of patients.
Thank you, Doctor, for offering your insight. We appreciate it. Let's welcome back Senator Gene Yaw and Raphael Bereshansky, Deputy Secretary for Health Preparedness and Community Protection at the Pennsylvania Department of Health. Gentlemen, you heard Dr. Jarvis discuss medication-assisted treatment. Senator, you've been a proponent of that all along, and you still are.
Absolutely. I agree with what the doctor said. It's a tool that's out there and it helps people function. I mean, what's the difference between medication-assisted treatment for opioids versus a person who must take something for diabetes or heart medicine or something like that? I think that to some extent, there's a stigma attached to this whole thing that goes along with it. I know that medication-assisted treatment relies heavily on buprenorphine, the federal government still requires doctors to have special training to dispense that drug, and then also they're limited the number of patients, which I don't understand that at all, when on the flip side, in order to prescribe opioids, you don't need any special training. But in order to combat them, you do, which makes no sense. So there was some relaxation in that particular requirement by the feds, but it's minor. It had to do with the interview process rather than actually what happens and what you need to do as far as the training. But in Europe, I think in France, they opened it up to all family physicians could prescribe buprenorphine, and I think that's a way to go here with medication-assisted treatment.
But not only buprenorphine, but naloxone. There's a standing order at pharmacies that if people need naloxone to reverse the effects of the drug overdose, that's been made possible at the state level. Correct, Ray?
You are correct. That's right. The Secretary of Health, Dr. Rachel Levine, has had two standing orders, actually, one for first responders and the other one for members of the public to actually utilize naloxone. It's very interesting because through a partnership with the Pennsylvania Commission on Crime and Delinquency, another one of our partners at the Opioid Command Center, we've distributed more than 80,000 kits of naloxone since the Naloxone for First Responders program has begun. And that naloxone alone has resulted in more than 17,000 documented overdose reversals. So this is an area, naloxone, that we are very clearly focused on. And as one of the physicians, I think it was Dr. Jarvis, but it might have been Dr. Lynch, who said, we can't get people into treatment if they're dead. And naloxone is the medication that will reverse the opioid overdose and allow us to get the person to a hospital for a warm handoff and then potentially into a treatment program and hopefully onto recovery.
Are there any additional comments you'd like to offer?
Addiction is not a moral failing. Addiction is a disease, and we recognize that. There are resources there, whether it's the Pennsylvania Department of Health website, whether it's the Drug and Alcohol Programs website, any of the resources that have been mentioned in today's program, please, if you feel you need help, please reach out. We will be there to help you. Please, treatment works and recovery is possible, and we want to see you recover.
In the time we have left, Senator, is there anything you'd like to add, like what you might envision for the future as we continue to battle this opioid epidemic?
Well, I think that raising the awareness once again is the way that we're going to face the battle. We have to get everybody on board and educate them.
We need to continue to fight the pandemic and this epidemic simultaneously.
Well, I'm hoping the pandemic will end.
Aren't we all? Well, I'd like to thank our guests for being a part of tonight's program and for advocating treatments for the underserved. It's our goal for those suffering from addiction to use the information provided tonight to seek help for themselves or for someone they love. Please visit battlingopioids.org. On behalf of Pennsylvania PBS, I'm Paula Giacomo. Thank you for watching.
It doesn't take long to become addicted to opioids. In fact, 10 Pennsylvanians die from them every day. Geisinger is committed to ending opioid addiction with both prevention and treatment. In the last 3 years, we've reduced the amount of opioids we prescribe by 50%, and we've opened 4 outpatient addiction treatment centers across the state to help patients recover from addiction. Learn more at geisinger.org/recovery.
Additional support provided by the Commonwealth of Pennsylvania and viewers like you. Thank you.